Just want to say yes or no. Everybody, please respond. Can you hear me loud and clear? All right, I think I got everybody there. Okay, good. All right, Amanda, welcome. It's good to see you here this week. And of course, Brockton, Jonathan, Martin, everybody, welcome back. All right, this is continuing the third part now of the three-part series that we started with narrow and complex and wide complex tachycardias. Just to review a little bit, we're going to talk about the narrow complex tachycardias just to have a brief review and make sure that you don't have any questions from the other day. The narrow complex tachycardias really comes down to is whether or not the patient is having a regular rhythm versus an irregular rhythm. And then, of course, that down even further, we want to know if it's stable or unstable. These are the most important aspects. And if you keep it nice and simple, the 3 o'clock, 4 o'clock, 5 o'clock in the morning runs are going to be a little bit less intimidating if you could just let this stuff roll off your tongue. So for review, the narrow complex tachycardias, when they're regular rhythms and such, can involve AV nodal reentry tachycardias, the reciprocating tachycardias. Atrial flutter tends to be a regular rhythm, normal sinus rhythm and sinus tachycardia. Those are pretty much the regular ones. When you get into irregular rhythms, we're really talking about the big one, which is atrial fibrillation, although multifocal atrial tachycardia can be a part of that. Now, I'm going to say one thing about multifocal atrial tachycardia that will probably show up on the new National Registry exams. They did last year. They will probably again this year. They usually go through a 5-year cycle before the question is retired. But multifocal atrial tachycardias are rare birds, and they come about as a result of overdoses or overuse of digoxin or theophylline. Digoxin or theophylline. Theophylline is of course, a bronchodilator that COPD patients use. Most of those COPD patients are a little bit older. However, when theophylline levels start to get toxic, in other words, over a level that you no longer get any further benefit from bronchodilation, all they do is speed up the heart. They irritate the hell out of the atrium, and subsequently you get a multiple foci firing in the atrium. However, not enough of them to cause atrial fibrillation. So you get this multifocal atrial tachycardia. It looks like an irregularly irregular rhythm, but the difference is that you can see the P waves, and each P wave looks a little bit different in morphology. And that's how you pick up multifocal atrial tachycardia. The only question you'll see on it is perhaps a rhythm strip on a older patient who's taken digoxin or theophylline. If they specifically mention those drugs by name, they're looking for MAT, the MAT, the multifocal atrial tachycardia. All right, as far as the other irregular rhythm, atrial fibrillation, of course, the whole atrium is firing at the same time, 300, 400 beats per minute. AV node can't possibly let all of them through, but it does let a significant number of them through. I don't see atrial fibrillations really over 220. If you get something over 220, you're going to have something else probably irritating or contributing to the problem, and that usually becomes secondary to something else. For instance, hyperthyroidism, thyroid storm, some of the monster drink overdoses, caffeine, bath salts can do it, amphetamines, methamphetamines, and such like that. Atrial fibrillation is very rarely the cause of something. Atrial fibrillation results from something causing it, most likely congestive heart failure or an MI. So you'll get the narrow combination of breaking it down now from regular to irregular is that all you have to do now is determine whether it's unstable. The criteria that we use for unstable is chest pain, shortness of breath, difficulty breathing, abnormal vital signs. You get all that. The major criteria to determine whether or not your patient is stable or unstable has to do with mental status. If the patient has altered mental status, they're considered unstable. Unstable anything, narrow complex or wide complex tachycardia, irregular or regular. If it's unstable, it's cardioversion across the board, no questions asked. Everybody gets electricity. So just know, unstable, no matter what it is, gets cardioversion. Be careful to distinguish that from defibrillation. Don't get confused on the test. Read the question carefully. When it comes to stable rhythms, in other words, the patient having normal mental status, even though blood pressure might be a little low, pulse might be a little high, if they're alert and awake, we consider that pretty much stable. And subsequently, we'll go to medication therapy. For the narrow complex tachycardias, it becomes fairly routine that if it's a regular rate and rhythm or irregularly irregular, firing at a high rate, you can use adenosine. Adenosine in the emergency departments has become a mainstay therapy, especially for the narrow complex tachycardias. You hope for conversion. If you don't get conversion, at least you get a heart rate slowed down, and that becomes particularly advantageous. The beauty of it is that even in the setting of Wolff-Parkinson-White syndrome, it's not going to make it any worse. Even though there's an accessory pathway, adenosine's not going to make that worse. Wolff-Parkinson-White has one contraindication for medication, that's calcium channel blocker. You'll need to know that for the National Registry exam. Cardizem, or diltiazem, which is the generic form of cardizem, is contraindicated in any form of Wolff-Parkinson-White. You'll need that to know that in either a format of a question that says you have this rhythm strip, you see the delta wave on the strip, and then all of a sudden you get 5 answers. Which medication would you not use? Be looking for the calcium channel blocker, diltiazem. We don't use verapamil. I don't use Procardia. We don't use any of that stuff anymore. Diltiazem is really the only calcium channel blocker that we use routinely in pre-hospital EMS or hospital emergency rooms to break a narrow complex tachycardia. In anything else but WPW, if your adenosine does not slow it down, then you can go to cardizem and do so safely. You just have to make sure you're not dealing with Wolff-Parkinson-White. If it becomes unstable after one of these medications being given, then you're back to an electrocardioversion modality, and that becomes a little bit dicey that you may have missed the WPW. Don't feel bad if you do. A lot of them are masked, and you can't see the alpha or the delta wave in either the inferior or the posterior wall parts of the EKG. All right. Sinus tachycardia deserves a special mention here. If a patient has a rate between 100 to 150, the sinus tachycardia is the result of something else causing the tachycardia. And so you'll have to get into what's causing it. It could be dehydration, hypovolemia, excitement, methamphetamine use, drug use, cocaine use, etc. In these particular cases, you don't really seek to slow down the heart rate. Even if the heart rate hits 160 in the setting of trauma, you don't want to be slowing these heart rates down. They may be compensatory for something, and that's what's keeping the patient. Trauma patient with 60 blood pressure, 160 heart rate with a rigid abdomen, you're going to be treating the hemorrhagic shock and the hypovolemia, and you're going to be stabilizing the patient from that standpoint and leaving the heart rate alone. It's very rare that sinus tachycardia is the primary event to anything. Almost invariably, it's secondary to something else. Something else is causing. So in the case of sinus tachycardia, you treat the underlying cause. Hopefully that's fairly straightforward. The Restem, adenosine does a great job. Cardizem is its backup. Beta blocker is the backup to that. So you have your ABC, adenosine, beta blocker, calcium channel blockers. with everything except WPW for the calcium channel blocker. So the neurocomplex tachycardias, which are stable, whether they're regular or irregular, really comes down to ABC. And as long as they're stable, they come down to adenosine, beta blocker, calcium channel blocker. Pretty straightforward. Hard to make these anything worse than that unless you miss a WPW. If you use adenosine or beta blocker on something that you suspect is WPW, you'll be safe, no problems. All right, before we move on to the wide complex tachycardias, I wanted to give you this quick review on the neurocomplex tachycardias. And before we start wide complex tachycardia, I need to know from each one of you if any of you have a question about neurocomplex tachycardias. Very good. All right. So without any further delay, let's get into the wide complex tachycardias. The algorithm that I have given you on your articles, and Amanda, since this is the first time I think I've come in contact with you, do you have the articles that we sent out a couple weeks ago? Okay. Let me see if I can't throw it up on the board here. You can share it with me on this screensaver here. I'll make sure that you get this whole LLSA articles. The first two articles are really the ones that we're dealing with. These are emergency medicine board articles given to EMS medical directors, the subspecialty of EMS medical director. And these are the types of articles that we discuss. You'll also discuss the second one, which has to do with the use of epinephrine in out-of-hospital arrest and how it's coming under fire a little bit, which is pretty distressing considering epinephrine's been around since penicillin. But anyway, I'll leave that for your review. The page that I have pulled up here, hopefully on your end you'll be able to enlarge it a bit. Let me see if I can't do something with it here. All right, this is the algorithm that we're going to be talking about, is the wide complex tachycardias. Stop playing with the computer here. And the first thing that you wanted to ascertain with wide complex tachycardia in these particular patients is whether or not there's underlying heart disease. So the first thing you're going to ask the patient, thank you, Jonathan, for doing that. I did it. The first thing that you're going to appreciate about the patient is, sir, ma'am, do you have any history of heart disease? Have you ever had a heart attack? Not atrial fibrillation, not multifocal tachycardia, not electrical arrhythmias. We're talking about real physical, real deal cardiovascular disease. So that's going to be lesions within the coronary arteries. If a patient responds to yes, then the wide complex tachycardia that's present on your monitor is assumed to be ventricular tachycardia and is to be treated as such. Period. End of statement. No further discussion. you can see from the algorithm as you scroll down a bit, and I'll try and make this scroll down a little bit, as it goes down the side here, if the patient answers yes, it's ventricular tachycardia, and now your only decision at this, gee, sir, you got wide complex tachycardia, you have a history of heart disease, you're in ventricular tachycardia, are you alert 9 times 4? If they answer yes and everything, then you're going to go with your amiodarone. And some of the older docs are still out there, they still use procanamide. And some of the older systems, they still use lidocaine. But amiodarone, as you can tell, has replaced largely lidocaine and procanamide. In all but very rare exceptions, obviously allergies being one of them. And so your decision at this point is if they're stable, you use the amiodarone bolus. That's 150 over 10 minutes, followed by an appropriate drip. You want to round something off, 30 milligrams per hour for a lightweight, 40 milligrams per hour for a heavyweight. Don't need to do much more than that. Half-life of amiodarone is in the half-hour range. Chances are you're going to be at the hospital before anything bad happens anyway. But that initial 150 milligrams got to be started right away. I don't care if you're 5 minutes from the hospital, because VTAC goes into VFib that quickly. You're not going to find too many people with a pulsed VTAC. You're not going to find people alert and awake with VTAC that often. However, you might. I've encountered it perhaps 4 or 5 times in 30 years.
Hey, I'm sorry. I've been teaching with Dr. Frame. In fact, I'm still got something going.
Just your luck out there as students getting out. What are you going to get on your first day? You know, you're going to get any clamping
Hey,
patient that's going to
Swiss, did
seize
you
while they're
ever get
delivering
your
a
work
baby, or you're going
schedule?
to get a wide complex tachycardia where they're awake. So go figure. Bottom line, though, is that if the patient becomes unstable,
Yeah,
and yet they still have a pulse with the VTAC, then you cardiovert. Clearly, if you get on the scene and they're unresponsive to VTAC, you go into defibrillation. That's your other algorithm for a pulseless VTAC or VFib. So, first decision to make when you come in, oh my God, I see a wide complex tachycardia. Is the patient alert and awake? Yes, fine, at least it's stable. Next question that you ask the patient is, do you have any heart disease? If they say yes, is VTAC, end of statement. Any questions about that simple part of the algorithm?
wow.
Okay. Now, if you get up top there and you ask, geez, we got a wide complex tachycardia, but the answer is no, I don't have any previous heart disease. I don't know what's going on with me. Then the question becomes, at this point, is this a regular or an irregular rhythm? Now, it's the same decision tree at this point as the neurocomplex tachycardias. Once you get to the point that the patient's stable from an arrhythmia standpoint, then you have to determine, is it regular or irregular? It's not going to be much different at this point than the neurocomplexes, except the medications that you're going to use. Now, as a general rule, despite the algorithm that you see in front of you, the general rule is this: if you ever get confused, or if it's 4 o'clock in the morning and you don't know what it is that you're looking at, just know this:
It's Dr. Frame. He's still teaching, and I'm having to make sure that his session goes. Oh, it's fine. No, he's as long as it's still going okay and he doesn't have any hiccups or doesn't.
The only decision you have to make is, I don't know what that is on the monitor, but
No,
it's
no,
wide.
no.
Is the patient alert and awake?
Teaching ventricular
Look,
tachycardia.
if
I know how to do that.
they're going to get electricity. I don't care what kind of tachycardia they got. But if they've got a wide complex tachycardia, you're going to deliver the amiodarone. So what you're seeing on the algorithm here, we're going to adjust just a little bit. We're not going to make a determination so much about the ventricular tachycardia if it's a regular rate and rhythm and the patient's stable. We're going to try adenosine before we decide whether it's SVT with the Barron-C or some sort of idioventricular tachycardia. It's not what we want to teach our EMS colleagues out there. So that part of the algorithm you can kind of disregard. Think about this. If it's wide complex and it looks, acts, or smells like ventricular tachycardia, it's getting amiodarone. Now, let's go over to the left side of your page there. The patient has a wide complex tachycardia. You ask them, do you have heart disease? He goes, no. She goes, no. Then you come down and you find out it looks pretty irregular. So now you're going to deal with three possibilities here. The first is going to be whether or not they're stable or unstable. Obviously, unstable gets cardioversion, and there's no question about it. The second is atrial fibrillation. Now, atrial fibrillation with aberrancy or atrial fibrillation with WPW can give you a wide complex tachycardia. So when you get your rhythm strips and you see a wild-looking QRSs and such, then you have to go at VTAC.
No.
If, however, you get any kind of notch on the downslope of the rhythm strip, any notch at all, it's called a Josephine's notch. And that notch is a dead giveaway for VTAC. If you don't see any notching and you see that the complex goes from wide to narrow pretty quick, it doesn't stay wide all the way through the rhythm, and there's a good chance you're dealing with atrial fibrillation. Whether or not that's associated with Wolff-Parkinson-White, sometimes these rhythms are too fast. The bottom line, again, is if they're unstable, you get cardioversion, I don't care what it is. But if they're stable, what do you run with? And the answer here is still, you can run with amiodarone. Here's the risk with adenosine. Let me scroll up just a little bit. And if you'll follow along on page 14, you'll see the topic wide complex tachycardias. And I want you to take note of something. The first sentence, adenosine is also useful in the differential diagnosis and treatment of wide complex tachycardias, but it should be given only when these tachycardias are regular, since the irregular wide complex tachycardias may be rendered unstable. Well, thank you very much. I appreciate that. I'm walking away from that. I'm not interested in diagnosing or experimenting out in the field, especially at 3 o'clock in the morning, especially 30 minutes away from a hospital. Remember, the first do no harm. You're not going to look at a wide complex, look at it and see it that it's regular, and so, hey, let's give it a try. What's the worst that can happen? We do CPR for 30 minutes. All right, that could be a problem.
Can I ask a question?
I would shy away and just go right to the amiodarone right away. You know, it's safe, it's effective,
No, you're
and
not.
you're going to get conversion.
My question is
number of
this.
times.
My question is this. Wait.
Adenosine's a dice roll.
Do they
If you
have
just happen to
cameras
be
on that
wrong,
floor?
you're going to have a lot more paperwork than the patient report to fill out. Plus a
Well,
couple
then
visits
tell
to the
her
state agency,
that
perhaps a discussion with
rather
an
than
attorney.
put you through that trauma
We
that you
prefer that
can't
you didn't do that.
why don't
Medical directors love
listen?
non-paperwork,
Why
and we
don't you
also love
suggest to her
non-issues.
that
And so
she
we're not going to go
pulls the
looking for 'em.
tapes from the
So the
cameras
best
showing
course of
you? Because
treatment
even
here
if they can't
is
hear you,
look at that first
she can
sentence,
pull together a series of
acknowledge the
clips
first
watching
sentence,
you
say,
and
gee,
following
that's a
you
very
from the
interesting
tapes
way
that
to
they
approach
have,
things,
and the
and I'm
CEO
probably not
will
going
be
to do
able to
it.
see you as you're talking to these people
Nobody's going to fault you for
with them,
going right to
the
the
way you're
amiodarone right away.
behaving. And
Certainly
then
you want to
all
avoid
she has to tell
calcium
them is,
channel blockers.
that's just who she is. That's how it's happening right there.
Calcium channel blocker in the setting of a wide complex tachycardia is tantamount to death. You will destabilize these rhythms, and they will go into full cardiac arrest. And so that
But they haven't been reviewing those videos. Those videos are only if
the wide
someone
complex tachycardias tend
that
to be a little
steals
bit
or they're looking for
easier
theft or something.
from a
They're not
standpoint
looking
of
at
what my
those
treatment
videos.
options are.
They're not looking at
It's
them.
either cardioversion or it's amiodarone. If your patient has an allergy to amiodarone, then you have to ask yourself, do I have lidocaine or procainamide in the drug box? If the answer is no to both, you're going to have to do oxygen, IVs, rapid transport, and put the pads
Well,
on.
then all you do
in
is just say, I
anticipation
don't
of a
know how to.
cardioversion.
You just tell the guy,
In the
look, I don't
likely
know how to
event
explain
they're
what I
going to
do
become unstable.
because I'm
I would
happy to be
suggest before
here.
any
I
therapies for wide
interact with
complex
people. I talk
tachycardias,
to them. I make
as
them
well
feel
as for
important.
narrow-complex tachycardias, that
And
those
that's all
pads
it
get put
takes.
on.
Is you make
A
them
lot
feel
of places,
important.
they allow you to put it right shoulder, left rib cage. I prefer the AP, one on the front, one on the back, a little bit slightly shifted to the left side, so that you can get direct electrical cardioversion right through the heart. rather than trying to have half the electricity skip over the skin surface, especially on a bigger person. You want those negative and positive poles to
Well, then you
put
just
as
tell
much
them
of
that.
that
No,
direct current
don't
as you
allow
can
them. You just
through
tell
the
them
heart
that. Say, that's
itself.
just who I am. I talk to people.
Okay,
I interact with
so
people.
in a
I
stable
make
condition,
them feel like I care
atrial
about
fibrillation or
why they're
variancy
there because I
is
do.
just
You know,
that.
that's impossible to
It's
teach to
an
someone. They
abnormal
have to have it
conduction through some
inside
scar tissue
to
or through
make
an
that happen.
accessory
If they
pathway
don't have it inside,
where
you
the
can't
atrial
teach them to be
fibrillation
that
not
way.
only causes a rapid heart rate itself, but because of the presence of the accessory pathway, you're not going through the AV node anymore. You're going through these side pathways or short circuits, which is causing repolarization or depolarization of the ventricle. Now, I want you to think about this. When you look at the heart, you see the AV node, and then imagine the Purkinje fibers going down the middle, the interventricular septum, and then out to the left and right ventricles. When they polarize at the same time, they repolarize at the same time as well. Depolarization occurs symmetrically. Subsequently, you get a narrow complex. Now, event, let's see if we got, looking for the heart here. And so, for instance, on my diagram here, you're looking at, I'm sorry. You look at the bottom of the heart here, and you can see the AV node right here. And then the
You don't.
bundle of
That's
his and
what
then
you have to tell
Purkinje
them.
fibers on
It's
both
not
sides.
something,
There's
you're
two
not
tracks on the
doing
left, there'll be one track on the
something
right.
that
When these
is
depolarize
learned, really.
symmetrically,
Doing
you get a
something that
nice
is
narrow
teachable to
complex.
someone
But
else.
let's say
You
that
are
your being
being
is
yourself.
firing over
You
here,
are
this
being a
focus is
human,
firing,
and
and
you
here's
are
your accessory
interacting with
pathway right
people,
through
and
this
and
isthmus
again,
here.
when you do that, when you reach
This comes down.
touch them and
What
you pay
happens
attention to
is
them and you
that this
compliment their clothes or their eyes
depolarizes.
or whatever,
The wave has to come all the
you
way
are
across to
not
this
just saying
side and
words, you're being
depolarize this
sincere
side.
from the heart,
Since they're
and they
not
know it.
firing at the same time, you're not getting a nice
No, you
symmetrical
didn't. Yeah, that's who you
QRS,
are.
and therefore the complex becomes QRS as the wave comes across, and you get widening of the QRS complex. The widening is because of abnormal conduction. So you have to determine whether it's
What
aberrant
has that got to
conduction
do
like
with who you
this,
are and what you're doing there?
or if it's something else. And that's when you get into irregular rhythms versus regular rhythms. If it's regular, you're probably dealing with ventricular tachycardia. If it's irregular, you're dealing with atrial fibrillation of some
But
sort,
that's not, that
even with
didn't
the
create who
variances.
you are. Now
How
it's
do
who
you
you
tell the
are.
difference between the two? The answer is it's very difficult. And even ER doctors have difficulty with that. Fortunately, most patients will respond to the amiodarone anyway. But I would encourage you, and we can make that the discussion for next time, is how to tell the difference between ventricular tachycardia and atrial
I
fibrillation
do,
with
honey, but
aberrancy,
I still say
SVT with aberrancy. You're
that's
going to
not
see
what
these
has
rhythm
created
strips
who you.
pretty
It may
often
have helped,
on
but I mean,
tests.
you
I can
can't
tell you
teach
in
that.
real
That's
life,
just, it's called
most of
being
these turn
a
out to be
human being. It's
ventricular
called being a
tachycardia.
person and
Why? Because
treating those
most
other
people with
people that come in,
arrhythmias have
your
heart
guests,
disease.
as people and making them feel like
All
that
right, back
that
down.
you're not just trying to sell them something. They're a guest and that you care about them. And when you say, oh, your eyes are gorgeous, they actually believe you because they can tell you're sincere. You cannot teach sincerity.
All right.
That's what you've got to try to explain to them, is that maybe the problem is not teaching people how to do this, it's hiring people who are sincere and
I would also encourage you when we have the
that's the point.
when we have the
It's
next
not trying to see what you're doing.
lecture
Teach it
series, and
because you
that'll
can't
be
teach it. It
next.
is hiring, but this is what I'm. Listen to me, honey. But this is what you
Pull
need
my
to tell
calendar here
them.
for a second. Hold
It
on.
has nothing to do with what you can teach. You can't teach what I do because I care about these people. I care about these clients. I care about them when they come in and they believe it.
On the 17th of
I'm
March will
sincere
be our
enough.
next
When
time
I
to
tell
get
them
together.
their eyes are beautiful, I
What I'll
mean
do
it,
is I'll
and they
throw
know
together a
it.
packet of
So the point is, you tell them,
30 rhythm strips that I will forward to
issue
each one of you.
is not trying
And
to
what we'll
figure out what
do
you're
is
doing
we'll
so that they
take them
can
one
teach
rhythm
it.
strip at a
Maybe they
time
need to
and
revamp
decide
their
atrial
selection
fibrillation,
process.
sinus
They're
rhythm with sinus
hiring and
tachycardia,
try
AV
to
nodal
hire
reentry
people who
tachycardia,
want to be there,
atrial
who care
tachycardia,
about other
multifocal
people. You know,
atrial
even if it's an
tachycardia.
assessment, something that they do to try to determine that
Don't let all
people
these
that
names
they're bringing
intimidate you.
in
When you get good enough
are
with this stuff and you
sincere
understand the
and they care about
pathophysiology
other
with all of them,
people.
it's going to be a piece of cake.
That's the
Most
key.
importantly, I've given you the most important tools that you need right now
Well,
to
it's the
survive
only
the
thing you can
field
tell them,
and
and it
survive
really
most national
what you're
registry
saying is
tests.
true. They
And
can't
that
teach it, so they have to change
neurocomplex
who they're hiring.
tachycardias,
You
get
can't teach people
adenosine,
to be
wide complex
compassionate.
tachycardias,
You
get
can't teach
amiodarone,
people to
and
be
anything
sincere. You can't
unstable
teach people
gets
to be
cardioversion.
to make others believe
Okay,
that they
the
care about them. It has
subject of
nothing to
wide
do with
complex
I want to sell
tachycardia I
this to
didn't
you,
think was going to take
but
us
in
that
the
long this evening
process,
because of
when
the
you're enjoying your job, you're enjoying life, and you're
really the
enjoying
simplicity of
communicating with
the
these people
algorithm.
and bring them
There
in and
isn't
talking
just
to them and
much to
doing
do.
little
You got
things with them,
cardioversion
they want
defibrillation
to
and you
buy
got
because they like
amiodarone.
you.
If it terminates, you're happy. If the patient terminates, you're unhappy. We're going to avoid this here, the adenosine. We're not interested in experimenting out in the field as to a regular ventricular tachycardia and gee, will adenosine work? So keep it simple. This is the KISS method. Just keep it simple. All right, a little bit of fun stuff here. I'm just going to throw a couple strips at you real quick, and then we're going to call it a night. Can somebody jump in and tell me this?
Uh-huh.
Everybody agree with Martin? Good. Jonathan and Martin, cool. Brock, cool. Amanda, cool. Okay, in reverse order, I want to hear from Amanda first, second, Jonathan third, Martin, you're fourth. What is this rhythm?
Mm-hmm. Well, I told you what to tell them.
It could be atrial fib. Um, it's marching out pretty regularly. It's got a heart rate of about almost 200. Um, so it could be atrial fib. Or answer there. SVT is a general rhythm, and you can call me at the
Yeah,
hospital and say, hey, I got an
you can't
SVT here,
teach
and the
it.
first thing I'm going to ask you
They
is, all right,
just, like I said, the
neurocomplex
only
tachycardia, you're
solution
going to
they've
say
got
yes.
is to try
Is the
to hire
patient stable,
people
unstable? You're going to
that
tell me
sincerely
stable.
care about
And then I'm
others
going to ask you, is
and
the,
want to be there.
that's the next
And that's the hard
important
part in today's society.
step to determine what kind of SVT
No,
it
you
is.
learned it from others. I'm not that caring. I don't really give a crap.
Noting that this rhythm looks pretty regular and rapid and the patient's stable, what would be one of your other choices of arrhythmia here?
Well, get married and be happy. To heck with it. If they expect too much, you just go find a new job. I mean, but yeah, they have to know that too. And I understand that perfectly. Every job I've ever had, because you know me, I can put out more work and generate more stuff in 8 hours than most people do in a
Possible
40-hour work
multifocal
week.
atrial
And
tachycardias tend to
because
be a
I
little bit
do that,
irregular.
they always
Um,
expect more. They
and
always
the P
want
waves,
more.
as I'm
They
them,
always
look
give
like
the
they're all
credit to
coming from the
someone
same
else while
source P
I'm
wave.
behind doing all the
Multifocal
work.
atrial
I
tachycardia or
know all of that.
multi-atrial tachycardia
Well, it
is going
did
to
for me
have
whenever I was trying to
different
get into
atrium
management, even
firing,
at,
maybe
Mother
3 of
Francis,
them,
whenever I was there. But
because they're irritated by
I
the
did. But the point I'm
digoxin,
trying to make
but it's not
is
going to be
that
all of them like you
I
see in atrial fibrillation. So
understand
3 of them are going to be
that
firing,
because
which
when
means
you
you're going to get
do,
3
they always
different
want you to
P
do
waves
more. But
before
you just
each
have to draw a
QRS.
line when that happens and say,
Although
you know what, this is what I'm doing. If you
you
keep
have to notice
pushing
that if
me,
3
I'm
foci
not
are
going to be happy
firing at
anymore,
different
and then I'm
times,
not
you're
going to
going to
be
get
able to
an
do what I was
irregular
doing before,
rhythm.
much less what you
So
want me to do now.
MAT tends to be more irregular than regular. But if you refer to your page 14 and look at your differential diagnosis on the left-hand side, you'll see that regular rhythms really involve atrial tachycardias, sinus tachycardia, although this is a little fast for sinus tachycardia, but the AV nodal reentries, the atrial tachycardia, the AV reciprocal tachycardias uh, tend to be
Oh my
more
gosh.
at play here. So it's kind of a strange strip. You're not going to see it on your national registry test. Don't worry about it. I
Wow,
threw
they
it
should be
out
pay.
there
If you're
just to
making
see
that much difference in the store, they should be
uh,
paying you a lot more
if
than
you can
anybody
get
else.
back into your algorithms, which is page 14, page 15. Just walk through the steps. Is it narrow? Is it wide? Is it regular? Is it irregular? In this particular case, assume that version. In this particular case, just march it down the algorithm, and you'll finally come down to one of two things. But the beauty of it, what drug are you going to use?
Well, I do. I know. Would you?
Very good.
Hey, but I'm going to be there before then. So which,
Very good.
what?
Adenosine. That's exactly right. So just take your time and just practice with some of these strips. Whenever
Oh,
you get rhythm
no,
strips,
no, no,
when you get
no.
your
When do you have to go
booklet
to work
of
on
rhythm
Tuesday?
strips from Percom and your particular chapters there, have these two
Shit.
algorithms sitting right
Honey,
in
I
front
don't
of you.
even leave to
First
go
question,
to East Texas
narrow
until
or
after
wide?
lunch on Sunday,
Second,
and my sister's
regular or
expecting me Sunday
irregular?
night.
And
I
then
know, but my
walk the
sister's
rhythm
expecting
down
Sunday
until
night.
you come to the final
Well,
answer,
I
which
could
isn't going to be
shift.
that hard.
Well, shit. And then, no, wait. Think. Let me think.
Okay.
Let me think. No.
Anybody want to tell me what this is? This is 12 lead EKG on a patient who all of a sudden went unresponsive on you.
Well, go fry the chops and I'll have to figure it out. Honey. Yes, ma'am. You've got me anytime you want me. I just got to get my stuff together. Okay.
Yeah, it's VFib, although Torsade is a form of polymorphic
Oh.
ventricular tachycardia. But the beauty of VFibs, it's so irregular that sometimes you can mistake it for Torsade. However, on an exam, the answer to this question will be ventricular fibrillation. Torsade will be one of the rhythm strips that we cover on the 17th when we meet again. Okay, one more, and I think we'll call it. Anybody want to tell me what this is?
Oh. I saw the deal about the puppy, but what kind of puppy are you getting?
Yeah, exactly right. This is STEMI. This is ST segment myocardial infarction, ST segment elevation myocardial infarction. Is it global? Might as well be.
Yeah,
You
you were
got the
telling me
whole
about
darn
that.
anterior
Yeah.
wall. The whole anterior wall is going to be V1, V2, V3, V4, V5, V6. That's a high lateral wall. I'm sorry, high anterior wall, which has knocked off the lateral branches. As you look at the different walls, V1, V2, V3, V4 constitute the anterior wall. V5, V6, in addition to leads 1 and lead AL, constitute the lateral leads. You can see you got ST segment elevation in each of these areas. This patient has a greater than 80% chance of death before you even get them to the hospital, and almost 90% death within the next 30
Oh,
days. This is a
yeah.
huge, huge MI, and it's going to lead to pump failure, which means you'll get on the scene. The patient will be initially hypertensive, depending on when you see them, but then ultimately
Oh
will go
my God,
hypertensive
they
on you.
blow
Once
you
they
out of
go
the water now.
hypertensive, the death rate is almost 100%. So getting these patients to the cath lab, getting that lesion open with a stent is going to be their only chance that they have of surviving
Oh, that's
this.
so
If you're
cool.
far from a
That's
hospital, I would schedule a
nice.
helicopter for these patients. If that's not available to you or because of weather conditions or whatever, then these are rapid move patients. You can give them the nitro, the morphine, the aspirin, and all the other stuff on the way into the hospital, but it's going to have to be
That's
pedal to the
funny.
metal
That is.
to an appropriate cardiac cath lab. So anyway, yeah, you say global, it pretty much, there
Oh
goes
my
80%
God,
of
how
your
funny is
ejection
that?
fraction. So for all intents and purposes,
Hey,
this is about as global as you're going to get.
real quick, there's
But I wanted to dabble a little bit on
two
the
things.
MIs
It's
here a
too
little bit.
bad
I'm not
that
sure where
Pat and
you're
Johnny
at
live
with
in Honduras
each of your
because Pat
cardiologies.
has the
We're
cutest
still going to be doing
puppies
rhythm
that live
strips,
in
but
perfect,
I
and
came across
they're
this
3/4
juice
Basset Hound and a quarter Beagle, and they're precious.
provided by Percom
They've
out
got
of
little
Dana,
short legs and
provided
little
this to me,
long
and I thought,
bodies and
yeah, I'll
big
throw this out
floppy
here tonight
ears.
just to see
Let me check
what's going on
before
with
you
it. No
get a
matter what you're
puppy.
seeing from
I'm
an
going home,
MI
on the
standpoint,
13th.
note
And let me get Pat to
that the
call
patient
Dr.
has a heart
Calderon
rate of
because he's the.
97, but it's still
I just got to figure out
neurocomplex.
how to get them here
Should the
because
patient
I'm coming
start
back
running
in
into an
April.
arrhythmia here,
But they're
the
little
more
old. They're not
likely
tiny
arrhythmia
anymore. They're
from
now they're
this
3 months old. I
particular
don't know. They're still puppies.
MI
They're still
is going
cute. They're still funny, but they're
to
not tiny. Yeah.
be VTAC or VFib, in which case you're going to be doing CPR in these patients. But just to give you a little taste of what STEMIs look
Yeah, well,
like,
let me
this
see
is
because I
giving
don't
you
know. I know Dr. Calderon's the national vet, which means he can get the paperwork and stuff done, but I don't know. And then I would have to see because I think I could take it on the plane.
MI would be the hypotension.
They're small enough. I think I could take them on the plane
But
and come back April the
for an
11th. But
anterior and a posterior wall to be involved
I
at the
got to
same
see what
time,
it's going to
that's
cost
almost
because
certain death
I
because you're
don't. I've
talking
got
about
bringing them
separate
out of the United States is easier than bringing them back.
altogether
So let me
infarction
check and I'll let you know
sorry,
as soon
being
as I get
included at the
home before
same
you buy
time.
something.
Statistically, that's a pretty improbable event. You don't have a higher incidence of posterior wall MI when you've got an anterior wall MI going on. You do have higher incidence of inferior walls and posterior walls being involved, and I'd be very careful giving nitro. I would not withhold nitro from somebody who's got a stable vascular dilation. I would give the patient a fluid bolus of 5 cc's and then give nitroglycerin. But I need that vasodilator in that patient, whether it's sooner
Okay.
or later,
Well,
that's
like I
up to
said, these were
you,
cute. I mean, these
depending
are
on
so
what you're
cute that
seeing
this
at the
lady saw
time
me the other day
in the
in
patient.
Honduras.
But
In
to say
Honduras,
there's an
and said,
absolute
looked at
contraindication
Minnie
of
and said, "I
nitroglycerin,
want that one. I'll give you $200 US."
you can't do that. You
In
can't say that. The only
Honduras, they
drug
make
that they have that
$15 a
can
day.
dilate
She
the
handed
coronary
over two
arteries
hundred bucks
is
US for that dog,
nitroglycerin. And
and they're not
somehow,
even full
some way,
blood.
as paramedics,
They're
you're going to have to
three
put on
quarter. I
your
mean,
best
they're my best.
pathophysiological
They're my Basset
interpretation
Hound
extrapolation
Hansel's
hats.
grandchildren,
You're going
and
to have
they
to
are
say, I got
so
to give you the
cute.
benefit of
Well,
this
let me see what I can
nitroglycerin.
do.
I
I will
can't do it
find out.
because your
I'll
blood
talk to
pressure.
Patrick tomorrow and see
Or
because, like I
before I
said, I
do
think
that,
they're
I'm going to
3 months
start an
old, so they're
IV on you, give
bigger,
you a
but
fluid
they're still
bolus, get
puppies. They're still
right-sided
puppies until they're
leads,
7, 8,
and
9,
if your
10 months
blood
old,
pressure
and
improves,
they're
I'll go
just
with
as
the
cute as they can
nitroglycerin.
be.
But if it doesn't, obviously you'll have to stay away from the
I
nitro.
know,
You
yeah,
also
I
have to
can't
stay
get this
away
one
from the
back
beta
until I come back
blockers
because
if
I'd
your
have to fly
system
it back
carries
with me.
beta blockers as well. Even
And I'm
though
coming back
clearly
in April because I got
indicating
2 weddings in
MIs,
April.
the inferior walls tend to be more bradycardic. And so the
Okay,
that
well,
would
you better hurry up and
contraindicate
let
a
me know
beta
because I got
blocker as
one wedding
well.
on the. Okay, well, let me call my sister.
No,
If I can tell my
I
sister,
don't
I will
take
be
any
at her
questions
house
that you have in
on
the
Monday
challenge
afternoon or
to
Monday,
what
late
we're
Monday
talking
morning,
about, because this is an open
Monday
discussion.
afternoon, Monday evening,
And
since
so
you're going
don't
to
ever
work.
feel bad
I can
about
go to her
asking
house
your,
Monday
or
evening. If I
feeling
go
bad
straight
about
to your
asking a
house on
question. But
Sunday and just put her off
even
one
though it's
day,
a
then I can
400
go stay
mile
the rest of the time with her.
dose and not a trip
Yeah, and then we be together Monday.
for this patient at least,
And then I will go to her house. So let me talk to my sister
dopamine,
and make
I
sure
think
because I
about
don't.
400
I think it'll
microgram
be
doses and
fine.
such. As far as
Yeah,
nitroglycerin,
it'll
I
be
start with
fine.
5 mics. and then I'll increase them to 7.5 and then the 10 mics. And I'll keep pressing them at that point by 5 micrograms
Let me
until
see.
I hit 50
I think she'll be
micrograms.
fine with it
Even though I've
because
had
then it
some
would mean that
patients up to
I
200
don't have to
micrograms on
move, because
nitroglycerin,
originally I was
most of
like,
our
if you were going to be
studies
off
show
like
that
Tuesday
after
night or
50
whatever, then I was going to
micrograms,
have to like go to her
you're not
house
going
and
to get
then go
much
to your
more
house and then
benefit
go
than
back to her
coronary
house.
artery dilation with the
Oh,
nitroglycerin. So
I
I'll boost them all
understand
the way
that,
up
but
to
I want to
50
see
if
her
they're
too.
still
So
having pain. Oxygen,
I'm
of
gonna. I
course,
think she'll be fine with it. I just got to call her. I'll call her tomorrow and talk to her or tonight, and then I'll let you know. But I'm sure she'll be
and
fine
so
with it.
don't
I mean,
hold
my niece
morphine,
said she's all
even on
excited because
somebody
you're
who's not
coming, and
having
I'm still
pain.
coming. I would just be coming one
You
day
don't know if
later.
they're
She
diabetic, they have
understands my
diabetic
schedule,
neuropathy. You
so
don't know if it's atypical chest
I will
pain.
call her and I'll let you know for
Could be in a
sure.
woman who may have different feelings of what pain
Probably
is all
tomorrow
about. It's
sometime
like
at the latest.
body
Yeah,
leave it
I won't call you
alone.
back tonight because I know y'all
So
are
don't
doing the
hold
wild monkey
morphine.
tonight. So
And remember something with morphine. Not only is it decrease anxiety, but it's also a vasodilator as
yes,
well.
I
And
love
it
you. I
could
will be
give a
there. I will
boost
be
to the
there. I promise.
nitroglycerin.
Okay. Just
And then most
give me to
importantly,
some time. I got
if
to
it
get this all wrapped up.
vasodilates
I'm
the
still sitting at my
pulmonary
office.
system,
So
you're going to be
you're
less
not
likely to go to
bothering me. You're
patient and
not
heart
bothering
failure.
me. I love you, and I'm just
There's
sorry I
going to be
couldn't
more
answer
blood
earlier.
accommodated in the pulmonary system, less likelihood of it backing up into the right ventricle or from the left ventricle into the
Yes, you told me some of it, but you'll have to fill me in the
lungs.
rest. So we'll just
When it comes
save
to
something to talk
60-minute
about whenever
flight
I get
cardiac
there.
center
Okay.
versus TPA at a local ER with 20-minute transport time, what's better?
Yeah.
IOP
Okay. I
flights,
love
local
you.
ER
Go
doc
finish
says
fixing and tell Chad I said
either
hi.
or. We're unable to fax our 12 leads in a
All right. I'll
right
talk to you later.
ventricle. Some ER docs are
Love you too,
skeptical of
sis.
our EKG analysis skills.
I
All right.
did. I mean, it was okay. It wasn't great, but it was okay.
And this is going to be one of those situations where you're going to have to really use your
No,
best judgment.
I'm here and he's in
Look, if you
Honduras. How did I do
got a
that?
60 over 40 pressure, the guy's having an interior wall, he looks like he's going to die, I would take him to get TPA. Once the
No.
TPA is
Yeah,
given
well,
and you get
we haven't
lucky
talked that much
and the
because the
patient
internet's
breaks
been
the
goofy down there
clot,
the last few
then you
days.
can
So,
helicopter them out to where you
so
need to
no.
be.
But anyway, go take care of
But
Chad. I
something
love
bad
you.
is about to happen.
Bye.
If you're 60 minutes away from a hospital, 15 minutes for the helicopter to arrive, and then 60 minutes at the hospital, there's a good chance you're going to lose any anterior wall. If your patient's stable and you can control them with nitroglycerin, and there's no law that says you got to hold the 3 doses. If your blood pressure's holding, you can give them nitroglycerin all day. That's why we put them on drips. I've had them on drips for an hour before they go to cath lab. That's a continuous drip of 5 mics. That would be equivalent of about 8 doses of nitroglycerin in 1 hour. If the blood pressure can hold it, keep giving them the nitroglycerin. Got to keep giving them the benefit of the vasodilation. And most importantly, keep going with the morphine. But you raise a very interesting scenario here, Martin. And this is where your leadership and your skills has to come into is what are you going to do that's best for the patient? And nobody, I believe, will give you a hard time given the scenario that you just outlined here. That if your patient looked that bad enough, I'd just get them to the closest hospital and get the TPA into them. As far as some doctors being skeptical of our ECG skills, you got to talk to the cardiologist. We try to describe an EKG to them over the phone, and they'll say, "Okay, I'll be right down to see the patient." They come down to see the patient. What's the first thing they do? They grab the EKG. Why? Because they want to see for themselves what's going on. Whenever you're dealing with a physician at any level, we trust what we're hearing, but you trust and verify. And sometimes even from some ER docs, especially in areas where they're not used to doing emergency medicine, even the specialists become skeptical of the ER doctors. So I don't want you to think that this is just a problem of ER doctors looking down their nose at paramedics. This is a problem that we have pervasive all the way through the system. This is why computer readings on the EKGs have become so important. It really has about 98% accuracy. And for the 2% it misses, it's not clinically significant. You may miss the occasional MI, but if the patient looks that bad with an EKG, you're going to be suspecting MI anyway. But if you've got the capability for an EKG interpretation while the EKG is spitting out, it's going to knock down a lot of errors and omissions. If you do have that capability on your monitors, so be it. You don't, then this is where calls to the hospitals are going to be important. If you don't have fax capabilities, I would start taking pictures with your iPhone and sending them off to the ER doctor. But somehow, some way or another, these EKGs got to get read if you're unsure about anything. And this goes back to the algorithms that we were just talking about. If you can keep this simple to narrow complex versus wide complex, regular versus irregular, stable versus unstable, that's all you got to ask. And follow the algorithm. You can at least get your first line therapy started and getting them into the hospital. If you've got this kind of EKG showing up and you know that it's an MI, then you get your nitroglycerin, your Mona, the whole Mona, morphine, oxygen, nitroglycerin, aspirin started on these patients. And you can get them to wherever you need to be pretty quickly. All right, I think we're just about at the end of it. I tend to read it, look like auto-interpret, then agree or disagree. Yep. That's all we do in the ER. I'll look at the interpretation and go, yeah, I agree with this. And I have to write the words, agree, the time that I read the EKG, and then I have to sign it. That's CMS rules. That's Center of Medicare and Medicaid Services rules. I have to sign off on it, or A, you don't get credit for the interpretation, and then B, it's going to be considered a reimbursement hit. In other words, if you do treatment without interpreting the EKG, then they're going to base your fee schedule on empiric treatment rather than definitive treatment based on your interpretation of EKG. And once you start taking $200, $300 hits for each patient you're supposed to collect on, you learn pretty damn quick that you're going to write your name on that EKG. When it comes to you guys out in the field, if your services are billing, that's going to be another thing. Agree or disagree and sign your name and the time that you saw the EKG. Any questions about that? Okay. All right, let's backtrack then. For the past 3 lectures now, we've talked about narrow complex, wide complex tachycardias, regular, irregular, stable, unstable. Does anybody have any questions about the last 3 lectures? All right, what Jane is going to do is she'll point you in the direction on the PERCOM website, and then on the 17th of March, we will go over as many rhythm strips as we can comfortably do within an hour on the 17th, and if we need to extend to the 25th and of course and such, so be it. That'll be our topics for the next couple of weeks, and we'll be able to help you through rhythm interpretations. All right. If there's nothing further, then I bid you all good night. Thanks for joining me tonight. Part of the whole 3-part series, and I look forward to seeing you.
Thanks, Dr. Frame. I hope you get to feeling better.
Thank you.
Good night, everybody. I'll go credit you if you've still got room for credit, and then get this all posted into the links if you want to go back and review it. Good night. Have a good weekend.